Caring for a loved one undergoing hemodialysis can be particularly challenging for Black families. So today we're going to listen to a video, and it's a panel. Going to have doctors and various ones on because March is Kidney Month, and even though this is a older video, it has some information we need to know about. We need to understand that Black Americans are disproportionately affected by kidney disease, with higher rates of conditions like hypertension and diabetes that lead to kidney failure. The structural inequities in healthcare, uh, access itself, and diagnosis also play a significant role. So I'm going to go ahead and see if we pull up this video. And yeah, let's watch and let's see what we can learn today. Okay, let's see what we can learn together. It's a panel and talking about New Yorkers, and this applies to people around the world. I'm going to
through today's conversation
hold the camera
that you
here.
will take with you more knowledge about kidney disease and why it disproportionately affects the Black community. Also, we want you to take away, or at least feel that you're involved in a real conversation in terms of knowing your risk and developing kidney disease. And finally, we want you to have the confidence and tools that you need to take when you step away so that you can slow or prevent kidney disease. Also today, our hope is to share perspectives on how kidney disease affects the Black community. And of course, it is my pleasure and honor to introduce our wonderful set of panelists. So joining us today, we have Thelma Barber, a kidney patient and a two-time kidney transplant recipient. Next, we have Dr. Kirk Campbell. He is a nephrologist from Mount Sinai and the incoming chair of the National Kidney Foundation Board of Directors. Next, Dr. Danushika Mataj. Oh my gosh, I messed it up. I'm so sorry, doctor. I tried so hard. But she is an assistant professor in the Institute of Health Equity Research at Mount Sinai in the Division of Nephrology. And please, 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 when it's your turn to speak, you will make the correction. Next, we have Dr. Antonia Esseline, who is a doctor and senior medical advisor in the Chief Medical Officer's office at the New York City Department of Health and Mental Hygiene. And she will be our moderator for today's program. Now, before we get started, I want to address a few logistics, if I may. If you're joining us by Zoom, please feel free to put your questions and comments in the Q&A below or in the chat. So that's the first thing. Secondly, if you're joining us by phone and have questions, you can email myself or my colleague, Chelsea Toner, and we will put our information in the chat so that you can send follow-up questions. And if you want to call us because you're not able to put your questions in the chat, you can call us at 212-889-2210, and we will put our numbers in the chat and our extension so that you can follow up. And finally, of course, today's session will be followed up with information and resources, so stay tuned. So with that said, I'm going to now turn things over to Tony, as we affectionately know her, and she'll be moderating this section. Thank you so much. And take it away, Tony.
Thank you so much, Monique. Super excited to be here with you all today. We're going to be using first names. Keep it familiar, keep it light, and let you know a little bit about me and why this is important. So again, my name is Tony Esselin. I'm a physician trained in internal medicine and in pediatrics, with a background in medical education and global health and public health. And I currently work as a senior medical advisor in the Chief Medical Officer's office at the New York City Department of Health and Mental Hygiene. I also take care of human beings of all ages, both adults and children, in a small practice in Queens, New York, my home borough. Got to shout out Queens. I was raised in Hollis, Queens, went to Hunter College, off the 6 train, and am extremely humbled to be here and to be able to work and practice in the community that raised me. And be here with you all today to have this really, really important conversation. So why is this topic important to me? It's because that in my practice in Miami, where I was trained, in my practice in Haiti, and in my practice in New York, the one organ that was both super fascinating to me and super irritating and made me feel completely helpless as a doctor was the kidney. It's fascinating how it works, how it's vital to keeping our blood balanced despite all the things we consume in terms of food and drink and the things that we put on our skin, how it's absorbed in our skin, and even how, if it's not 100%, it can still do its job to keep us balanced, but irritating in the fact that you can't feel when things are not working well, even though those kidneys are quite sensitive. If your blood pressure is too high, if your sugar level is too high, if your stress level is too high, if you're on the wrong medications, all of this can affect your kidneys and hurt your kidneys, and you won't feel it. You might not actually feel it. It's silent until it is not. And it feels unfair. And it contributes to my own personal sense of helplessness as a doctor when I see someone and it's too late. Imagine you feel fantastic and you are told by a doctor that you just met that your kidneys are not working at 100%. Imagine you don't feel great and you're told by a doctor that you just met that your kidneys are not functioning at 100%. Where do you go? What do you do? Who do you talk to? How do you process that information? Do you have to change today? Do you have to change tomorrow? Do you have to change next week? You know what? Maybe this wasn't a good day or the lab was on the fritz and that was a mistake. And these doctors are just trying to make money anyway, right? You feel fine or fine enough. And there's a lot going on in your life, right? And so you have a follow-up appointment, but you've got family obligations, you got to work, you got rent, et cetera, et cetera. And nobody called you from the clinic anyway, right? And so it can't be that important. Maybe you missed a phone call, right? Because you're dealing with life, a situation that's actually important to you today, in that moment. Or your doctor said something like EGFR and didn't explain it and used a bunch of scientific jargon that didn't make any sense to you. There are many times that folks come to my clinic for the first time in many years. They haven't seen a doctor in a while. And I'm the first one to diagnose them with chronic kidney disease. Unfortunately, it is also not unusual for someone to have been in and out of the health system, right? And still not know that they have kidney disease, either because it wasn't explained well, like I previously mentioned, or there was no follow-up, or if it was overlooked. Generally speaking, 1 in 3 New Yorkers are affected by kidney disease. And 90% of those people who are progressing through kidney disease don't even know it. There are many chronic diseases that disproportionately affect the Black community. High blood pressure, heart disease, diabetes, certain cancers, and we need to include kidney disease on that list. Did you know that the incidence of kidney disease for Black people in America is 3 times higher than for white people? So the beauty of the kidney is rivaled by its ability to be a silent killer, especially in my people, in the Black community, whether born in the US or if they immigrated because of how this country was built and structural racism in medicine. And that is one of the things that we'd like to discuss today. And so in that spirit, I would love to turn the mic over to one of the most important people today on this panel to share her story. Thelma, why don't you tell us a little bit about you?
Hello, everybody. I am Thelma, and Tony, you did such an amazing job with that opening. And I'm telling you, I'm literally fighting tears because I wish I would have had you as a child. When I was diagnosed, they did not diagnose me. Let me get it together. I'm sorry, everybody, but that passion that you speak, that heart, that fire is what I needed when I was 12 years old. And my mom took me to the doctor because all I had was swelling hands and feet. And the doctor would just always push me off or tell me, I'm sorry, would always push me off to the side and tell my mom, oh, she just needs to lose weight, and I'm sorry that they always push that off because growing up as a kid, I was very active. I ran track in Colgate Games. I marched in the New York Lancers, Drum and Bugle Corps. I jumped the rope. I was busy. So always throwing off my concerns to losing weight was devastating because that was not the problem. Excuse me 1 minute. I'm sorry.
Wow, guys, wow.
All right, get it together, girl.
So touching.
I'm sorry.
You take the time you need, Thelma. You take
This
the
is
time
so
you need.
touching.
I'm sorry. So when I did go to the doctor, my mom was a single mom. We lived in poverty. And if
my
we didn't
God.
have government health insurance like Medicaid, we would have to go to the free clinics. And when she went, raising six kids alone is devastating enough. And then going into a doctor's office and trying to process what they said, she did what they said. Okay, we're working on the weight. But my mom,
She's having some issues right there with her internet, guys. So we're gonna just hang in there, and hopefully she'll come back. Hopefully they'll be able to get her back,
we
guys.
never really cooked
There she
unhealthy. We didn't have quality foods, but she did her best to put the best food she could on the table. And they just ignored me for years until when I got out of college, I was able to afford commercial health insurance and I was feeling like I had the flu. I went to the doctor and they did a dipstick in my urine and told me I had blood and protein. Now I didn't know what that meant, so then they referred me to a nephrologist. When I went to a nephrologist, they had ran all these tests like lupus, HIV, sickle cell, everything came back negative. But finally, when they did the biopsy in 1993, I was diagnosed with IgA in nephropathy, nephrotic syndrome, which is a benign kidney disease. Now, that disease, they didn't know how I got it, where it came from, and basically there's no cure, as everyone knows, to kidney disease. And as you said, Tony, it is a silent killer. Because I had no symptoms at all except for the swelling hand and feet. I never heard the word edema. I did not have any of the comorbidities of diabetes and high blood pressure. My family didn't suffer with any of that. I mean, my mom did have her own health issues growing up. As a child growing up with her, she had a lot of heart issues. But other than that, no one had those comorbidities that go along with this disease. So once I was diagnosed, they said, okay, you can go and to dialysis, or they told me that I can take some fish oil vitamins, but there really was no treatment except for dialysis, which was in the center, which I did do. But then I pursued a transplant. And when I pursued that transplant, my brother and one of my sisters and my husband were all matches. And I was able to get that transplant, life-saving transplant in 1998 by my sister. That transplant saved my life. I was able to go back to work, have an active life instead of being tied down to a machine 4 days a week, 3 hours a day. And at the end of that 10 years, my kidney started to fail again with the same symptoms, but I was able to get pregnant. And I was able to have my blessings, my twin boys who were born prematurely, 2.4 and 2.9 pounds, but they are thriving and doing fantastic today. But this disease is a silent killer, and you really, really have to take heed to any type of symptoms that you have.
Thank you so much for sharing. It sounds like it was such a roller coaster experience for you, especially coming out of nowhere, somebody who was inherently healthy, weight loss. Don't get me started on weight loss being blamed for everything, right? But I would love to take this opportunity to turn it to Kirk and ask you, what do you think about Thelma's story and what she has to share?
No, I mean, definitely, Thelma, thank you so much for sharing that story. Truly inspiring your fortitude, but at the same time, disappointing and not too surprising, right? To hear the challenges, right, that you faced one, in getting the appropriate diagnosis and the challenges, right, in finding out that you actually had IgA nephropathy, which fortunately now we actually have some approved treatment options decades later, really in the last couple of years. So, we have had some recent successes in the nephrology space, but you've definitely exposed a lot of the work that we still have to do, right? And a lot of the barriers that you faced are certainly still there. Many of them that you mentioned are structural, right? It's really access to care. It's really identifying, the physician who will communicate in an appropriate manner that will empower you as a patient and your family and support systems, because that's important, right? We're all in this together. We always think about the in office visits as crucially important, and they are, but it's everything else that happens outside of the office visits that really have the biggest impact on your health, right? That you mentioned, nutrition and access to healthy foods, and Tony mentioned a lot of the other life challenges, right? That will present barriers to effective communication, right, between patients and physicians. So I think, Thelma's story really illustrates a lot of what we know and a lot of what was exposed during the most recent pandemic, right? About the inherent inequities in access to care and the tragic consequences that can have, right? With increased mortality, hospitalizations. And from a kidney disease standpoint, folks can go decades without getting the right diagnosis and treatment. And that's truly unfortunate.
Yeah, absolutely. I think that you make such an important point about communication with the human beings that we're charged to take care of, right? And their families, right? And integrating the people that are their support system, or identifying when they don't have a support system. What are the support mechanisms that we can put in place so that we can effectively communicate with folks? Dinashika, can you tell me a little bit about communication and how that actually impacts the way that care is delivered, and the structural barriers to achieving real health equity for real?
Thank you for that question. And I want to also take a moment to just pause and express so much gratitude to Thelma for sharing your story. Frankly, without you and others sharing these stories in our rooms, when we have the privilege to take care of you, we cannot highlight the things that are known structural barriers and the things that we need to continue to vigorously pursue in terms of addressing other types of racism that are being experienced in your life, in terms of barriers, access to healthcare insurance, poverty, access to food, all of these things. And also, without hearing these stories, we don't know how we can actually build upon the strengths that you have and that you bring and that communities bring to the table. I think the most kind of sobering part of the story that you shared is this piece about not being seen, not being heard, and not being believed. And
Sure.
that is on us. That is on us as individual providers who have this honor of being trusted to care for you. And that is on us to solve this problem of decades, really contributing to decades of earned mistrust and skepticism of this very system that is supposedly entrusted to care for you. And I think communication is what is most vital about that. And it starts, I think, by listening, truly listening. And the thing that I always try to remember and I always say is nobody knows their body better than you coming into that room. And so when you are feeling something, anything, right? We've already heard about how all of these manifestations of kidney disease might be silent, but when you are experiencing one of these things, or somebody in your family has had kidney disease or has been on dialysis, bring that information to the table and insist that it be heard by us. Because it is really our job to partner with you to improve health and to really identify what your goals, what your values are, and then, find solutions. And I think along the way, trying to, on our side, on the provider side, we have a responsibility to really hear you when you are bringing up your experiences of structural barriers, lack of access to insurance, lack of access to getting the medications you need, challenges in terms of getting to your visit, so that we can really, again, partner with you to find solutions to that, because it's not all on you. So that is where communication plays a role, and that is sort of our role in terms of identifying and fixing these structurally racist barriers to care.
Oof, we are preaching today, y'all. We came to church, kidney church, okay? I'm loving what you're saying here, Danishika. Thank you so much for that. And I would love to ask you, Thelma, a little bit about what is your reaction to that?
My reaction is you are 100%. One thing that I found out in my journey is that it's a partnership, but historically, I feel that African Americans in America, there's always a system in place where we feel like we can't challenge that system, or we're afraid to challenge authority in that questioning your doctors, or even if it's having a question for the police. We act and we act like we are afraid to empower ourselves. And I've gotten to where I've gotten because when I became a kid, an adult, you couldn't push me to the side anymore. I'm fighting. You're fighting for your life. And it's important for you to stand firm and know that you have the right not to seek treatment with that physician if you don't like them. You can change. It's okay.
Yes.
Before I even settled on my diagnoses, I went to like 4 nephrologists, one because I was in denial. I couldn't believe it. But more importantly, it just was not the right fit. So it is important for you to find a doctor, because I realized that going to the doctor, it's about strategizing. How are we going to plan my life with this disease? Because the key to anything in life, it's about learning how to manage that disease, but not letting that disease control your life. You control it. So partnering with your physician, number one, is extremely important. But more importantly, we're talking about patients ranging from pediatrics all the way up to geriatric. So I think that when you're in those appointments, you have to bring someone with you. I think a great support system is what helped me, because in the beginning, when I really was diagnosed in 1993, I was just really in a fog. I'm hearing what the doctors are saying and I'm doing my best to process, but having my husband there with that pen and pencil and writing that information so that we can go home and discuss what our options of treatment are was important. But what you can do today, you have these wonderful patient portals. And in those patient portals, I always say, hey, I'm your favorite stalker patient, because I will be in that portal at midnight, 1 o'clock in the morning. I can't sleep. I'm rolling over. If my head hurt, I'll say, can I get in and get an appointment? If I run out of medication, hey, can you refill this? So that patient portal is your best friend. And in that patient portal, they give you a printout of all of the medical history, a medical summary. So even if you are getting access to that patient portal and you don't understand what the doctor's saying, find someone to assist you with the technology to go into that portal, print out your medical history, see all your diseases, see all the medications you're on and what they're for. And then you and your family can take time to sit at the table and discuss, how are we going to attack our health, your health, and be on top of those things.
I love that. I love what you're saying. And you're talking about empowering yourself to demand good care and to understand exactly what's happening, right? And so I alluded a little bit earlier to EGFR and talking about scientific words that we don't know that. We didn't learn this in school, right? In regular school. And, if your doctor is throwing around an EGFR, you see that in your printout, and nobody told you anything about it, right? You're not going to be able to ask about it. So, Kirk, what would you say about EGFR? What's the hullabaloo around EGFR? And why is it important? And how has it actually contributed to Black people in particular getting misdiagnosed?
Yeah, sure. So we throw around the term EGFR quite a bit, and it's essentially a term that stands for the estimated glomerular filtration rate. So it's how well the kidneys filter blood. One of the most basic functional units in the kidney is the glomerulus that filters blood. So essentially, the way I often explain it to patients, it's an estimate of your kidney function, and you could consider it a percent kidney function measure, if you will, right? Where a number more than 60 is considered close to normal, right? Part of the issue is that for several decades, the formulas that have been used included a race coefficient, where patients who were Black or African American actually had their kidney function overestimated by these equations, right? So as a result,
Really?
many folks had a delay in their referrals for kidney transplant, didn't get enough credit, sufficient credit for wait time on the wait list for deceased donor kidneys. So it actually caused real harm, right, to have these equations that are again, quite efficient, easy to derive from a simple blood test being used. Fortunately, through the work of the National Kidney Foundation, the American Society of Nephrology, a lot of key stakeholders, an updated EGFR equation was published at the end of 2021, and that's being implemented across the country. The major academic centers, including our own, were quick to adopt it. It does not use this race coefficient. It's more accurate. And furthermore, I think a lot of the transplant regulatory authorities now are looking at giving back appropriate credit to anyone who is disenfranchised or compromised, right, by the use of this race coefficient in estimating kidney function. So, again, I think the medical community recognized this issue, certainly after a long period of time, but still there being steps taken to rectify that. And I would just add as well,
Awesome.
for folks who have questions about their own risk for kidney disease, there's a Minute for Your Kidneys site, minuteforyourkidneys.org, through the NKF, where they can take a brief survey to estimate their kidney function.
Okay. I'll document that.
Great. And along those lines, I think that what you've alluded to is that there's been harm done to the Black community as a result of this coefficient and this addition of race, when race should not have been a part of the conversation in the first place. And so what do you tell a patient who a year ago had normal kidneys and nothing's changed, and now this year, because we've taken out race in this calculation, and now they do?
And that's actually happened, right? Because you can actually see the trend in the lab reports where a patient may actually have, you would think, not a big change in their kidney function, but just the way it's calculated and estimated would show a difference in the estimate. And these are informed conversations that have to take place between patients and providers, acknowledging, the use of the race coefficient in the previous formula and some of the inaccuracies and harm that was derived from that use, and discussing what the new estimates actually mean. And I would just also add that we're talking about estimates. There are ways to actually measure the kidney function more accurately, right? We can view the estimate as a screening test, if you will, but there are other more detailed, confirmatory, accurate modalities available. And those often become necessary when we really need a more accurate measure of kidney function.
Dinashika, I would love to hear what your perspective is on this issue as well.
I think that was perfectly covered by Kirk, and I will also just add, though, that if you are a person who had a Black race coefficient or African American race coefficient added in your prior kidney function estimation, and you had that lab done, let's say at a primary care physician's office, and you might be trying to seek a kidney transplant, this is the time to try to get that information from that office, identify that record, and go to your transplant center with that information, because that is exactly what they will be looking for to try to get you the time that you might have been disenfranchised from having before back. So this is an attempt at almost a reparation that is so needed, and hopefully is a model for other institutions and other aspects of medicine that can learn from what the kidney community did here. It's identifying a harm, telling truth about the harm that was done, and then finding a way to repair it and make sure that it doesn't happen again. So that's that. And I think the second thing is, if you are a person who now is identified as maybe having an abnormal kidney function or EGFR, now that the race coefficient is gone, this is a really nice opportunity to say, hey doc, what's going on? What does my urine look like? Am I spilling protein? And getting some of this other information that's so important to identify what other medications you should be on, what other tests need to be done to figure out what may be causing your issue. And then asking, how does this impact my family? How does this impact other people in my community? And so there's some spread of knowledge that can hopefully occur from this as well.
Amazing. I think we've talked a little bit about these numbers and what do they mean and testing. And so, Thelma, can you tell a little bit about exactly how, with this understanding of numbers, what would you tell your peers? What would you tell your family members? What would you tell somebody that you came across in the street? Honestly about what do you do? What's the first step of trying to have this conversation with your provider? In your words and understanding exactly what testing is, why do you need to look at your urine? All these things. What does all of this mean to you?
Well, it sounds complicated, but I want everyone to know it can be simple. And I say that because we don't need to get into the technology of how you go into check the creatinine and you're saying the EF, you're going into different terminologies. I always tell my family, we're African Americans, and it's a possibility that we may get some diabetes, because I know that has turned to be out some genetic issues that are starting to come out through African Americans. So if you have high blood pressure, or if you're just concerned in general, because my kids were born premature, they're doing great today. But as a parent and everything I went through as a child, I demand, could you please just do a renal panel? Wow. You don't even have to get technical about what that renal panel includes, but you can demand a renal panel, and that can show you exactly how that kidney is functioning and anything else that's happening with your kidneys. I would also recommend that you demand every year at your annual physical a hemoglobin A1C. Yes. Let's see what's going on, because diabetes, I have family members who are walking around with 600 smiling and should be in the hospital, because these diseases are silent killers. And then, just as my own personal thing, I would recommend everybody to get a blood pressure monitor. They're very inexpensive. And keep yourself a little medical kit. I mean, even buying a testing monitor, your glucose monitor is not that expensive if you wanted to buy that, or if you had a concern, maybe talk to your doctor about it and say, listen, I have a history of the family, or I don't have a history, but I have a concern. Have a little medical kit with those little things to check on for yourself. Definitely your blood pressure. But when you go, I tell my family all the time, at your physical, ask for a renal panel, hemoglobin A1C, and make sure you're checking your blood pressure on a regular.
Wow.
And your urine.
Yes. And your urine. Yes.
Nephrologists love their urine.
Yes. Well, okay. So the thing about urine, when I was first diagnosed, I had a lot of bubbles. Yes. And I was concerned about the bubbles. So that was one form that maybe something was going on. I didn't realize it.
Yes.
But, definitely get your urine checked along with that.
Excellent, excellent. And you don't, just to be clear to everyone, you don't have to go to a nephrologist for all of these tests. You should be able to get them from your primary care doctor. And, going back to the conversation that we were having before about communication, just like any service, if you are not happy with the service you're receiving from your physician, get another one. Get another one. Okay, you don't have to stay there, right? There are other physicians. There are a lot of physicians, honestly, who love what they do and want to be there for their communities. You have to find them, right? And don't be frustrated. The same way that you go around, you don't like that barber, you don't like that barber, you don't like that hair salon, you don't like that Walmart. You're gonna go to this one. You're not like that supermarket. You're gonna go to another one. It's the same for us. If we're not doing you justice, then we don't have the right to take care of you. And you should find somebody who has the right to take care of you. And so don't be bogged down. Don't be frustrated. Take a deep breath and say, prioritize yourself and your health, especially if you have family, especially when you have people depending on you. And I think that a lot of us in our communities, we get into this bad cycle of like, I'm needed. I don't have time. I have to do this for my kids. I have to do this for my spouse. I have to do this for my siblings. I have to do this for my mom. I have to do this for my dad. And then you keep putting yourself lower and lower and lower on the priority list. And what we are all screaming about here on the panel is don't do that, because you might feel okay today. You might even feel okay tomorrow. But after a while, it's going to catch up to you if you don't figure out exactly what's going on and making sure that you understand all the things. And you don't have to have, a deep understanding, but you shouldn't leave a clinic appointment being confused. If you are confused, then you need to either go back and make a phone call, ask for a phone call, or find another physician who's going to talk to you.
Yes.
Because we are here, we are out there. It's not the people on the panel. We're out here. So don't be afraid to make a move. I think that I wanted to ask Dinashika, from your perspective, right? What is it that you feel you wish your patients knew before they get to you?
Yeah, I think that's a great question, and I think several folks have already covered the fact that it's important to come with some sense of what is it that you're feeling in your body, right? What kinds of impacts of kidney disease or other diseases, diabetes, hypertension, et cetera, might be going on in your family. So are there people in your family who've been impacted, who are on dialysis, who are on transplant? We need to know that information. And then I think a third thing is, what other medicines are you taking? Because the kidney is such a sensitive organ, sometimes some medicines that we're taking actually can cause harm. And some of these are sold over the counter. And too much of them can be a problem. Yes. And so coming equipped with a sense of, not only the medications that you're prescribed, but the medications that you're taking over the counter for various aches and pains is really important, because we might need to address some of those. And then finally, I think, again, taking the time to go to this National Kidney Foundation website here for the Kidney Risk Quiz, having a checklist of things that you can bring to the table along with a supportive care person if you can. What's my blood pressure? What is my kidney function? And what does my urine look like, as Thelma so perfectly stated before? Sort of demand that knowledge.
Amazing. Kirk, I wanted to ask you, as a primary care physician, at what point should I start sounding the alarm?
Yeah, I think that's another area where there are great resources provided through NKF with a heat map that we often share with our trainees and with our primary care colleagues, where based on a patient's kidney function, how much protein they have in the urine, there's a gradation in risk, right? Literally a green, yellow, orange, red coding. And that also will give some general guide and as to how frequently patients should be seen and evaluated per year. So I really think it depends on how much protein there is in the urine, how quickly the kidney function is declining, So that rate of decrease would be something to watch out
Wow.
for. If there's sudden changes as well in the level of protein in the urine, that's also something to be aware of as well. So the trends are important.
So is it okay if I get a patient and I think they have stage 1? Do I call you?
Yeah, you can. Again, so just to clarify again for the audience, I think that's a trick question Tony was asking me here. So stage 1, it's actually still kidney disease, but the kidney function is pretty normal, but you could still have kidney disease with a lot of protein in the urine. You could still have cysts. We haven't talked
Wow.
about kidney stones. We haven't talked about, electrolyte, potassium, sodium abnormalities. So there are a lot of other things that could be happening related to the kidneys, and it could still be stage 1, which sounds, not too bad. And it's not from an overall function standpoint, but still there may be a reason to see a nephrologist. So
Wow.
great question. Thanks.
Can it be prevented? Can you prevent it from progressing?
Yeah, that's sort of what we hope to do in all cases, right? We don't have regenerative therapy as well to reverse a decline that's happened, but a lot of our efforts are geared towards slowing progression. That's exactly what it is, and I think every medication that gets approval, that's the claim that they make to the FDA that they could potentially slow the decline in kidney function, right? So I think, there are some basic things that certainly are within the domain of the patient. And we talked about diet and exercise and overall, healthy habits, but also there are medications that have been shown to be effective in slowing the decline in kidney function. I think there's some questions in the Q&A about the genetic underpinnings, which we could potentially get to later. But those may also play a big role in driving kidney disease progression. And maybe, with advances in, biomedical research, we can get to precision-based therapies to target some of the genetic underpinnings as well.
Awesome. So it sounds like what we're hearing here is that we want you all who are participating in this webinar today to understand your risks, get care sooner rather than later. Like if you're one of these people like, I'd rather not know. I'd rather not know. Don't do that. Take a deep breath. It's better to know. It is better to know so that we can do something about it. It's not a death sentence. It doesn't have to be. Okay. And if you have the right team, you can get help. And ask your questions. Ask those questions. Make sure that you're relentless in being your own advocate and ask the questions that you need to make sure that you feel good about taking care of your health. I had a couple of questions in the chat. I wanted to give you guys an opportunity to ask those questions and then answer those questions. And then after that, we'll have some closing remarks from our panelists, and then I'll kick it back over to Monique. The first question that I received was, what is the type of kidney disease that Thelma was diagnosed with?
I was diagnosed with IgA nephropathy, nephrotic syndrome. It is I wouldn't even use the word rare anymore because, as you said, Kirk, a lot of studies are going on about that disease. But yes, it is one that I couldn't control. I don't know how I got it, where it came from. So that was the disease that had taken my kidneys.
This is for either two of our fabulous nephrologists. Why do you think that doctors don't use dipstick testing more often? I don't know the answer to that as a practice.
Yeah, well, I'll start off a little bit. I mean, I think it's a hot topic these days because there isn't a general screening guideline in adults, actually children for that matter, to check kidney function and look for protein in the urine among the general population, right? I think it's typically done for individuals who are deemed to be higher risk, right, for kidney disease, so patients with diabetes, hypertension, and so on. But the dipstick is, again, it's a useful screen. It doesn't give a quantification of how much protein there is in the urine. It just tells you whether it's kind of there or not. But then there would have to be confirmatory testing done to actually measure how much protein there actually is. So it's a bit of an initial screen that can be helpful, and it's also great for patients to have dipsticks at home when they're diagnosed, with conditions like IgA nephropathy and others, to really detect a flare, right? They think they may be having a flare, and they can also do the dip at home and then contact the physician to have a confirmatory test in the office. I don't know if Danushka has
Wow.
other things to add on that.
And I think that is spot on. And I am hopeful that through advocacy from the NKF and others, we can actually push the U.S. Preventative Service Task Force to make kidney screening a guideline for all people living in this country. That would be a big.
Okay, guys, I don't know if we lost her. Seems like we lost.
Awesome.
Here we go.
The next question I have is, after elimination of the African American EGFR calculation, when comparing to past lab results, are new values different from the earlier EGFR as determined previously for the general population? I answered yes, but I would like to get some elaboration.
Danushka, you wanted to start?
Sure. So really, yes, it's a resounding yes. And the truth is that the higher your kidney function might have been estimated to be, the kind of larger the change you might see in it is. And the second thing is, yes, if you were previously calculated to have a kidney function using a Black or African American race coefficient, you will expect to see a lower kidney function. And I think, again, seeing this as an opportunity to get educated and to seize opportunities to prevent and detect early and figure out what's going on and intervene early on disease is really what you should be advocating for with your physician with this information.
Excellent. Do you think that genetic testing may help identify at-risk individuals early?
Yes, absolutely. In fact, it's been estimated that among all comers, patients with kidney disease, about 10% actually have monogenetic etiology, so a single gene mutation that's causing the kidney disease, and that's very high, right? And that includes everybody with so-called hypertensive disease or diabetic kidney disease. If you have a protein spilling disorder, like focal sclerosis, about 30% of those patients may have a genetic etiology. So we're seeing a lot more of the genetic contributions to kidney disease. And in patients of African ancestry, there have been specific gene variants, apolipoprotein L1 or APOL1 as it's called, that's been closely associated with the progression of chronic kidney disease in individuals who have two high-risk mutations. So I think, we're doing a lot more genetic testing. It's become a lot more available. And so there is hope, again, that we may be able to intervene successfully in some of these genetic disorders.
Okay, I have two more questions, and then we will kick it back to Monique. The next question is, are there at-home tests patients can use to monitor their kidney health, like glucose monitoring?
Good question.
I mean, I think I can start, not specifically to my knowledge for GFR estimates that may come, but, there are patients, as I mentioned, who have access to dipsticks at home to kind of track, and then it's usually done more when patients have an established diagnosis of a protein spilling disorder, and, they can self test at home for any flares, but that may come, right? That may be something that could be developed in the future.
And we got a couple more. We have time. So overall, what is the best therapy and treatment protocol for CKD at this time? Danushka, you want to take that?
Sure. So, I think it sort of depends on the cause of the kidney disease, but fundamentally, I think a few things I can say that we know for certain. One is that blood pressure control really matters, and there are certain medications or certain classes of medications that we know can slow the progression of kidney disease, particularly for people who have protein spilling kidney disease or diabetes related kidney disease, or even IgA nephropathy, for instance, with, again, protein spilling as a primary cause. Something to ask your physician is, why am I or am I not on an ACE inhibitor or ARB, a specific class of medications to treat this. The second thing to know is that, one of the really important novel things that's been introduced to medicine in the last several years is a whole new class of therapies for people who have protein-related kidney disease, diabetic kidney disease, and heart failure called SGLT2 inhibitors. And there's a whole, there are multiple brand names of these, but these have really been blockbusters in terms of slowing the progression of kidney disease. And so it's another thing you might want to say, to your physician or healthcare team, am I a candidate for this? And if not, why not? And I think the third thing I'll leave with is, for those who are in the audience who might already be progressing through their kidney disease, or they're nearing the stage when your team is saying, we need to start thinking about dialysis, your kidneys are failing. One key thing to remember is to advocate for getting all the information about all of your options. Dialysis doesn't always have to be just done in a center, where other folks are providing that therapy. There are therapies at home that can be done for dialysis. And most importantly, transplant continues to be the best option in terms of quality of life, in terms of morbidity, or having other kind of complications related to dialysis. And the National Kidney Foundation has wonderful resources on how to speak with people in your life about whether they might be a donor of a transplant for you. And this is something that, again, if you're at that stage, speak to your kidney doctor, to your team, about what are my options for treatment outside of dialysis, if that's the only thing that you're hearing.
Great. Great answer. Another question that just came through is there an association of Black nephrologists in New York, like a professional society?
Great question.
No, not to my knowledge. In New York, I think there are obviously national professional organizations, and there are directories that folks could also search for physicians that they're interested in seeing as well, but not a professional association to my knowledge.
Ooh, we're getting a lot of engagement now. This is kind of fun. What is the difference in having a private nephrologist versus a nephrologist at the kidney center? Who should you be followed by?
Great
So
question.
I guess the question may be pertaining to private versus in an academic setting, if I'm understanding correctly. Because there are also nephrologists who are mainly at dialysis units. So, I think just to clarify, when patients, are on maintenance dialysis, they do see a nephrologist within the dialysis center. If you have a kidney transplant, usually also see a transplant nephrologist. But there are nephrologists who primarily practice in the private setting, and then there are others that are affiliated with academic centers. And as we've discussed earlier, the decision that you would make would really depend on your own personal relationship with that physician and your comfort level in communicating, and whether you feel that you're getting the answers and the care that you deserve. So I think as Tony mentioned earlier, you have options, right? You have choices, and really consider those options well. One thing I'd say is, for some of the rare conditions, some clinical trials that might be emerging, those may be more available in academic centers rather than the private setting. So just to be aware of some of those opportunities.
All right, we are coming short on time. One last question, and then I am going to open it up to the panelists for final remarks, and then Monique. What is this? Is protein in the urine common?
Okay,
Dinasheena,
great
do you want to
question.
take that?
Great question.
Yes, that's a great question. It is actually common in a whole range of different diseases, and I think what matters again here is, you know, what is the cause of this, and then what are the trends in time, and does it meet a threshold where we need to be thinking about something like biopsy and thinking beyond diabetes alone for some of these other types of conditions that have been mentioned, for example, nephrotic syndrome, related conditions, FSGS, etc. So the amount really matters, trends in time really, really matter, and yes, it is common.
Mhm.
Excellent. Well, we are coming up on time and a few more questions came through. I'm going to see if Monique and team can get answers, get those questions to you guys, and if we can provide the answers on like an FAQ on the website,
Nice.
so you guys can refer to. I just wanted to give some time to our panelists to share some final thoughts. I wanted to give the honor to Thelma first, and then Danushika, and then Kirk.
Thank you, Tony. I would just like to say thank you so much for giving me the opportunity to be here today to speak from a patient's perspective. But one thing I want you all to know is that advocating is a must. I am currently an advocate for the National Kidney Foundation, and I've gotten that passion from my journey. My journey is that there are a lot of people who don't have the courage or the faculties or the know-how to fight for themselves. So if I can be that voice for that person, that is what I will do. I'm going to sacrifice. I'm going to live this life, not only for myself, but I am a firm believer that I am my brother's keeper. And so if it's up to me, as I am growing in knowledge and power and in strength to share that to my next brother and sister, that is what I'm going to do. This disease is wicked. It is a silent killer, and I am going to tell you, empower yourself with courage. Know that you are, as I said before, fighting for your life. Don't take this fight standing down. I want you to know that you have the right to question. You don't have to just take medication because you're prescribed medication. If you are prescribed medication, why am I taking that? What is this going to do? What is that going to do? Make sure you take the time to read those inserts that come with that medication, so you'll know what that medication is treating you for, but also what some of your how would you say, some of the side effects of the medications can give you. You know, dealing with kidney disease has not been a pretty journey. I know I make it look good, but I just throw a little joke in there. But seriously, you have to stay on top of your health. You have to hydrate, and once you do get a diagnosis, follow up. If you don't like what one doctor's telling you, I went to 4 doctors before I accepted the truth that this was my life and this is what I have to deal with. As Danishka said, know your options. You do not have to dialyze in your home. And right now, the National Kidney Foundation, I just came from DC, we're fighting for legislation to give patients the opportunity to have home access. COVID opened up so many wormholes in our healthcare system to let us know the importance of having a doctor that we can talk to, like these beautiful Zoom sessions, having someone to speak to as you're going through this process. You're gonna go through, I went through depression, I went through denial, I've gone through anxiety, but you are not alone. I want you to please go to the Kidney.org Foundation, National Kidney Foundation, Kidney.org website. We have peer tutoring there. Partner, we have to check back in on our neighbors, and we have to know you are not alone. We can do this as a community and fight this disease together. I love you all. Thank you for this opportunity, and God bless.
Wow, wow, wow. And guys, we're going to stop right there. I'm telling you, where's my clapper? That's all I can do. That is an outstanding Zoom video that they did. And even though this is March and that was done last March, the information applies to today. Oh my goodness, guys. Please, please, please let me know your thoughts on that information. Let me know your thoughts on that information. And if you know anybody, now this was in New York, and I'm in New York, but this does not have to be New York. That information is for people around the world, for people around the world. And with things changing right now, and they're trying to do crazy things to Medicaid, Medicare, all the systems and this type of a thing, guys. We also know that sometimes you can be into a health network where you maybe can only go see this doctor or this doctor or this doctor. But I'm telling you, they brought out some nuggets in there. And you don't have to just go to one doctor. You got to ask questions. All the things that we talk about, guys, and in caring for yourself. So, family caregivers, I pray that you grab hold of this information. One of the things that Thelma was saying, that the lady that was a kidney recipient, she shared when she received her diagnosis, she was in a fog. It was like the same thing happened with my husband. With my husband, I was there. And when he received his diagnosis, it was like he could not. It was like, what? I don't. Whoa! What did he just say? What did he just say? And by me being there and able to help hear some of that, and then later us being able to discuss some of that, it really helped, guys. Guys, I pray that you enjoyed this video. This is Queen C. Pinkston, your caregiver supporter. Make sure you like, you share, and you subscribe. And guys, I'm going to see you in our next video.